Okay, go ahead.
Welcome to our presentation. Today, Nicole, Doris, and I will introduce to you the Stark Law, which will focus on talking about the first two sets of laws. Getting into our slides, let's talk about who wrote the Stark Law. The author is Fort Lee Stark. It used his last name as the name of the law, and Fort Lee Stark was born in 1931 in Wisconsin. And before he introduced this law, he worked as a bank executive for about 10 years. And then he was a Democratic congressional representative of California in 3 different districts from 1974 to 2012. So this is an ideology chart, and it's just a little extra information that I found. And this chart shows where STAR stands in the House of Representatives in 2013 among the Democrats. And talking about the rationale for the policies, the reasons for having a START law include preventing any self-referral in physicians from getting more than necessary. Otherwise, there will be conflicts of interest, increased costs for healthcare, and limited competition. Talking about self referrals, the START law actually punishes the outward manifestation of a referral as a money-making opportunity. It's like a medical referral of a patient between a physician and at least one other outside entity, such as a physician or uh, a physician and a hospital, or two physicians not in the same group practice. But the Stark law does not forbid internal referrals within an office or group. For example, the referral must be by a physician involving one of the DNS, which is the designated health services covered by Medicare or Medicaid. So in the next part, Nicole will take us to learn more about the individual Stark Law 1, 2, and 3 briefly.
Stark 1 was included as part of the Budget Reconciliation Act of 1989, and it became effective in 1992. It was designed to create restrictions to prevent conflict of interest through self-referrals for clinical or laboratory services as part of the Medicare program. There was an effort to make sure this law only impacted those trying to defraud the system by including exemptions for those with appropriate business practices. The goal was for physicians to always put the needs of the patient above personal gain. Stark also only applies to designated health services, or DHSs, as being said. These are services such as, but not limited to, things like imaging, occupational therapy, home health services, outpatient services, and prosthetic devices. There is confusion between Stark and another mandate called the anti-kickback statute. The basic differences are that the anti-kickback statute is broader in its scope and requires specific intent, as well as how they are penalized when they are violated. The restrictions under this law specifically prevent physicians from referring patients to any facility or clinical laboratory that they or any member of their family has a financial relationship with, unless otherwise specified under the aforementioned exemptions. A financial relationship is defined as any direct or indirect ownership or investment, or any direct or indirect compensation agreement with a facility. Again, this can be personal or associated with a family member. This relationship can range from anything from a leasing agreement for a space to practice or equipment used to owning stock. It also restricts the presenting or payment of any claim that occurred due to a restricted referral. Stark 2 was part of the Omnibus Reconciliation Act of 1993. It was intended to clarify exemptions and expand Stark 1 to include Medicaid and additional DHS services. This was important because the DHS list is very specific, and if the service is not individually listed, it is not restricted under the statute. Also notable under Stark 2 is the Secretary can review a situation and grant exceptions where he or she deems appropriate. While not specific to this report, it's notable that this issue is continuing to be addressed with several phases of implementations, and finally Stark 3 in 2008. One of the issues being looked at is again changing the list of specific DHS services under the ban. As mentioned before, there are exemptions to the Stark laws. A group practice is one of the most common exemptions from the Stark regulations. Some of the defining characteristics of a group practice, as required by the mandate, are that there must be 2 or more physicians legally organized together, where they provide at least 75% of their patient services within the practice. How the finances are determined is key to the exemption, so that a physician cannot take advantage of a patient for any financial gain. The group must share the overhead expenses and make decisions about the group practice as a group. The way physicians are compensated is also important, so the number of referrals or value of the service from a referral has no bearing on how they are paid. Essentially, there must be a pooling of both expenses and revenues. There are other qualifications under the mandate the practice must meet to be exempt, but the direct purpose is that physicians cannot financially gain from unneeded services. Patients have the right to know if their physician will financially gain from the use of specific treatments or equipment, such as owning part of a practice facility, or if they are part of the development of a new treatment or technique before consenting to a service. Doris will now explain the enforcement and penalties of violating these regulations.
Okay, enforcement of Stark 1 and Stark 2. The CMS, or the Medicaid office, is primarily responsible for enforcement. Health and Human Services joins the Department of Justice, or the DOJ, and the Office of the Inspector General, or the OIG. At this point, most violations are turned in by whistleblowers. 5 cases turned in by whistleblowers resulted in over $137 million in fines. Most of the legal advances in Stark law jurisprudence have been made predominantly as a result of public whistleblower actions under the False Claims Act, FCA. In addition to helping advance the law interpreting the statute, whistleblower actions involving Stark law violations have achieved recoveries on behalf of the government, which in turn has had a deterrent effect on healthcare fraud. Without these whistleblower actions, many of which the government declined to intervene, the Stark law, while admittedly complex, would remain even less defined. Penalties for violation. Violation of Stark law can result in fines 3 times the program's loss plus $11,000, a penalty for each claim for a prohibited referral, denial of payment, refund of payment, exclusions from federal health care programs, and prison. Repealing Stark. Support seems to be growing for significant changes to the Stark law. The conflict of interest statute restricts physicians from making referrals based on financial considerations. But Congress has expressed concern that it is inhibiting new delivery models in which providers collaborate closely and share financial interests. The United States Department of Health and Human Services is now headed by Representative Tom Price, a Republican from Georgia. He is a doctor and a frequent critic of healthcare regulations that HHS controls. A particular law firm predicted that the United States Department of Justice would resist efforts to totally eliminate Stark, which has generated many fraud cases over the years. But one of the attorneys there said that policymakers might take action to streamline the law's notoriously complex exceptions. I think there is a way to simplify the exceptions and make them less complicated, Attorney Medea said. Congress may take some action on legislation, but if HHS takes a different view of the Stark law, the department could make some regulatory changes to lessen its burden. In conclusion, the Stark law is a system that provides patient protection against fraud while ensuring quality health care is not easily achieved. The Stark laws aim to create a balance but it is evident that the issue is certain to garner debate as the laws are continually refined.
Awesome. Great work. Stark is a pretty interesting topic to cover, actually, and some of the things that are within it. The regulations there to help prevent some of those issues as far as like the self-referrals and different things like that. So again, great work. You covered the topic well. Typically I'll ask you guys what the most interesting thing was that you learned as you're studying this topic, but it's almost 11 o'clock where Nicole is. So
That's okay. We
Nicole
can
needs,
like.
it's okay. I don't grade you on the questions. So
Okay.
no, you guys covered the topic really well. So I appreciate that. So I'll go ahead and stop recording, but hang on for just a second.